Hepinize katılımınız için çok teşekkür ediyorum. Kısaca Amulya Saxena'yı ben size tanıtmak istiyorum. Çoğunuz tanıyorsunuz belki. Yani çocuk cerrahisi ailesinde Avrupa'da önemli figürlerden bir tanesi kendisi. Graz'da eğitim alıyor. Münster'de eğitim alıyor. Daha sonra Graz'da çalışıyor uzunca bir süre Michael Hallward'la beraber. Şu anda çalıştığı yer Chelsea Children's Hospital, Imperial College London'da, Londra'da çalışıyor şu anda. Bizim açımızdan çok yoğun olarak bildiğimiz şey endoskopik cerrahiyle yoğun olarak ilgilenen arkadaşlarımızdan bir tanesi. Bir diğeri de EUPSA'nın seçilmiş başkanı kendisi. Murat abi sizin bu aşamada söylemek istediğiniz bir şey var mı? Yoksa ondan sonra ben İngilizce olarak bir kere daha kendisini tanıtacağım. Sonra sözü ona vereceğim. Duymuyor Murat abi herhalde. Okay. Amulya Saxena is a pediatric surgeon. Right now, he's working in Chelsea Children's Hospital. He was trained in pediatric and neonatal surgery at the Medical University of Münster, Germany. He was a research fellow in surgery at Boston Children's Hospital, Harvard Medical School. And before joining to Chelsea Children's Hospital, he served as associate professor and deputy director in the Department of Pediatric and Adolescent Surgery at the Medical University of Graz. He worked with Michael Hallward, Austria, and he also was the head of experimental fetal surgery and also tissue engineering unit. He is also a fellow of many international and national pediatric surgical societies. We are very happy to have him right now here, and he will talk about tonight about the management of complex pediatric ovarian pathologies in the endoscopic era. Amulya, thank you very much again, and right now you can start your presentation.
Thank you very much, Aydin, for this invitation, and it's great to see all my friends in the Turkish Association of Pediatric Surgeons. I think we have had good opportunities to interact with each other in the past few years. Unfortunately, because of the present crisis, a lot of things have been put on hold, and I hope things return to normal soon, because it's generally affecting our work with a lot of children. I would like to today, as I mentioned to you, talk about the management of complex pediatric ovarian pathology, something which has been underestimated, and there have been ad hoc decisions. And I would like to focus on a lot of things which we have taken in our subconscious and are not actually focusing on what is evidence-based. So the topics which I will focus today on are para-ovarian cysts, streak gonads, asynchronous bilateral ovarian torsion, benign and malignant ovarian tumors, and especially I'll touch upon giant mature teratomas in the endoscopic aspect. And the next thing is neonatal ovarian cysts, something which we presume that it's just very simple, but there's a lot of evidence which is missing on these topics. The first one will be para-ovarian cysts. And these cysts account for around 17 to 33% of adnexal masses. This is based on the reporting from different countries. The most common are in the third and the fourth decade of life. So generally, when you see these figures, they should not affect the pediatric population. They arise in the broad ligament between the fallopian tube and the ovary. And the preoperative diagnosis by means of ultrasound is very, very difficult, because when the child presents to you, you're quite perplexed what exactly is going on. MRI is done to complement ultrasound, but finally you find during surgery what is going on. This is a child that presented to us in 2007, 2008, and she came with the abdomen with this distension. Her friends are making fun of her in school, saying that she's pregnant, and she was only around 12 or 13. She says, I cannot be pregnant. And it happened for a long time till she came to us. Our registrar at that time did an ultrasound just to find out, and the registrar came to me and says, there's a lot of fluid in there. I do not know where to go ahead. We decided to go for an MRI, and the MRI showed us this huge cystic mass inside. And it's very difficult to delineate what a cystic mass like this would be in the abdomen. It could come from a lymphangioma, it could come something from, could be an enlarged choledochal cyst, it could be also something from the ovary or something else also. But the size of the mass and MRI, you generally know it's not very easy to delineate ovaries also. We decided to go with that option, going through the scans again and again, that it might be an ovarian problem. So endoscopically made a small incision over there. First of all, implanted, put a purse string suture on this cyst, put in a catheter inside, putting some glue on the side so that we do not have leakage. And we just aspirated the entire fluid. This was total of 9 liters what came out finally when we got out this from this structure. Then we went in laparoscopically and then saw that, as you can see where the star is, this is the entire cystic area. And we could see remnants of the normal ovary over there. And it was possible to do a complete resection of the cyst, which was done at this point, and we left the ovary in place. So when you look at these para-ovarian cysts, they are classified as mesothelial, paramesonephric, or mesonephric, and this is according to the histology and the embryological analysis. The neoplasms, they could be cyst adenocarcinoma and papillary carcinoma, constitute 2.9%. So it is very important that you just also take the tumor markers before you try to look into these cysts or try to go inside laparoscopically. Laparoscopic unroofing is unsuitable for para-ovarian cysts. Just to make a small window is not the right thing. You have to do a laparoscopic cystectomy, and the extraction of the cyst after that is the method of choice in the management of such cysts. We move on to the next pathology, and that is Frasier syndrome, something also very unusual in the pediatric age group. What exactly is Frasier syndrome? It is characterized by male pseudohermaphroditism, slowly growing nephropathy, and that's the most important clue that you have to keep in mind, or your pediatricians have to keep in mind. They frequently develop gonadoblastomas. Now, because of this, these are often diagnosed when the patient is evaluated for primary amenorrhea, which means the child will be around 9 or 10 when the periods start and you're not finding, or something that the mom finds it wrong. And these children have streak gonads. Now, this is what a 6-year-old was diagnosed because of primary nephropathy, nothing wrong with the gonads. And the further investigations, came to the Frasier syndrome. This is a laparoscopic view of those streak gonads, in which I performed laparoscopic complete resection of the gonads as well as the fallopian tubes. And this has to be done bilateral because you have to also put 2 sutures to fix the uterus to avoid rotation of the uterus. Well, at least that is the approach that I took. When we sent it for histology, we were surprised that we saw that there was alkaline phosphatase positive, and hematoxylin eosin also showed a lot of unusual cells. This patient, like I said, was diagnosed when she was 6 years of age, because most of the patients with Frasier syndrome are diagnosed in the 2nd or 3rd decade of life when they're evaluated for primary amenorrhea. The XY karyotypes have been extremely high, have a high risk of gonadal dysgenesis and transformation into gonadoblastoma, which is malignant. As we saw in this child, she already had a malignant transformation at the age of 6 years. And laparoscopic salpingo-oophorectomy is warranted in these patients. The next topic which hit us and which we had to go into do some research was asynchronous bilateral ovarian torsion. Now, ovarian torsion was first described very early by Sutton in 1890, and bilateral ovarian torsion, that means involving both the ovaries, was first reported by Warneck in 1895. Bilateral asynchronous ovarian torsion was first described by Barron in 1934. That means you have one ovary that is torsed, and then after some time the child comes, or the girl comes with a second ovary not torsed. So this is something which we call asynchronous bilateral ovarian torsion at ovaries which are torsed at different time frames. Now, something which is very important with this aspect is the possible mechanisms which have been stipulated for the torsion of the adnexa. Abnormal long fallopian tube, mesosalpinx or mesoovarium, adnexal venous congestion, as in premenarchal activity, jarring movements of the bodies, and functional ovarian cyst. They may be additive predisposing factors. Now, it's very difficult, and we do not have real evidence what exactly is the implication of these factors and which of these factors really play a role, because when you see the data coming out on ovarian torsions, most of the literature just says there was a torsion and ovary was either rescued or not rescued. Now, the question which comes after this is unilateral torsions. If it is in a very bad state, the ovary, do you do an ovarian sparing operation? And the second question, which all the pediatric surgeons ask, what do you do to the normal ovary? Do you do a PEXI or you don't do a PEXI? So we'll try to look for quite a few of these answers, and let's see what we found out on these topics. There is a high risk of recurrent torsion in premenarchal girls with normal adnexa torsion. So that means you have normal adnexa, all the factors which I mentioned before are not there in these girls, but you still have a risk of torsion, and you have the risk again when you go back in a couple of months, or these girls could present again. Now, another aspect of these torsions is that there was found to be a recurrence of 15 of 125 normal ovaries. That means the recurrence happens. You try to put back the ovary after the first torsion, and then you have a recurrence in 15 of these 125. What was even more interesting, that ovaries which were fixed, the question which I raised, after oophoropexy, there was also a recurrence in 1 to 19. So that means that even oophoropexy is not very clear whether that helps or not. The question which is raised over here is, how was the oophoropexy done? Was it done with the resorbable suture, or was it done with a suture which is braided and non-resorbable? So this is data which is more important, the technique and how it was actually done. The question after this which arises is again ovarian torsion, which is bilateral. Sequential bilateral ovarian torsion of normal ovaries, these were not cystic ovaries, in a prepubertal child was described very well in 2006. But what was interesting is that asynchronous bilateral adnexal torsion in a 13-year-old, she had one torsion, the ovary was removed because of the bad state or the ischemic state of the ovary, and the second side she had the torsion and the second ovary was removed. So the girl completely lost both the ovaries. So this is something which is very, very difficult to accept, just removing the ovary. And the question arises is, what can you do in case these ovaries are kept back? This is just a few slides of the PEXI technique, which I prefer to use with ethibond and 2-point fixation of the ovary on both the sides. Very careful to avoid the vessel injury over there while you're doing it, and of course, intracorporeal suturing while you finish this. So we did a systematic review on asynchronous bilateral ovarian torsion, whereas there were no guidelines or consensus statements which were found about this topic. Our systematic review revealed in the 27 years which we could access the data, revealed 13 articles, of which only 9 met the inclusion criteria. And most of them, as you can see, are case reports, because none of us have very big series, and only 4 original articles. But on the whole, you can see that the sample size was very low because we had only 17 girls in this analysis. And of course, as you can see, they're all present in our pediatric surgical age group, ranging from 1 to 16 years. What we found out that the approach worldwide until now has been as follows. Most of the people, as you can see below, prefer ipsilateral oophorectomy. That means they prefer to remove the ovary. And then on the other side, they did a contralateral oophoropexy. In some of the cases, as you can see, 23%, 4 of these 17 girls, they had bilateral oophorectomy. So the literature also shows the removal of both the ovaries. In 3 of these girls, which is 18%, detorsion and bilateral oophoropexy was performed. Now, I looked into the survey and how people look at oophorectomies or oophoropexys. There was a national survey, and I find this is a very important survey. It's not very old. It's not from the 2 or 3 decades ago. It is from our present era, 2015, just 5 years ago. In the United States, looked at 2,041 ovarian torsions. Was surprising that oophorectomy, that means removing of the ovary, was practiced in 78% of the patients. Release of the torsion, that means releasing of the ovary and then just leaving it in place, was practiced by 15%, that is 317. Out of the people who released the torsion, oophoropexy was done only by 6%. This data is important because the release of torsion increased from 1998 to 2001. That means the practice in 1998 was to do more of oophorectomies, and over a period of time, this decreased to 9%. But what was more important was who was doing it. Non-teaching hospitals were compared with teaching hospitals. And it was important to see that there were higher rates of oophorectomies in non-teaching hospitals and lower rate of release of torsion in non-teaching hospitals. So it is very important that where the child lands, that you finally see what is being done with these ovaries. So most of the hospitals now have moved towards releasing of the torsion and also decrease in the number of oophorectomies. Now, conservative management, everyone will ask, you're keeping back a dead ovary and leaving behind some necrotic tissue. What do I do? And this was very important publication which came out in 2000, said that the most important complication of conservative management is post-operative fever. Just be 100% sure that this child will get post-operative fever. And you should start antibiotic management in these patients from the very beginning. So do not wait for the fever to develop and then start antibiotics. Immediately after surgery, you start antibiotics for the severely insulted ovary and try to secure and keep the ovaries. Just to mention in our review, because we looked at asynchronous bilateral ovarian torsion, we did not see any of these torsions associated with any kind of tumors. The next topic that we would like to move is benign and malignant ovarian masses. And of course, in this, I would like to mention something about giant mature teratomas. Mature teratomas, as you know, are the most common type of ovarian neoplastic lesions, which are present in the pediatric group. And most of you, I'm sure, have done a lot of them. Mixed tumors with cystic and solid consistencies could be benign or malignant. And this is one of the lesions which always bothered me for quite some time, because I did not know how to go about with a half cystic, half solid lesion. I was not very sure that, should I go for a complete resection or shall I look at it based on the 3 tumor markers? And that's what I will come down to, that how we expanded this surveillance of these patients. Of course, if you have a malignant tumor and in mixed tumors, you should avoid any spillage of material, laparoscopically or open, because you can cause upgrading of these malignant lesions. Now, the problem with tumor markers is that they present in wide variations and are not reliable to establish the diagnosis of ovarian neoplasms. The complexity is much more than what we think it is. We looked at a series which we published in 2008, just first of all looking on the consistency of the tumors. When you saw that was cystic, that is a very nice indication. You can be more or less sure that you're looking at a benign lesion. When you look at mixed cystic and solid lesions, that's where the trouble comes in, because you're not sure if it could be benign or it could be malignant. And the solid mass, at least in this series, what we had, was definitely malignant. When you go to the other side and you see that the origin of these ovaries, now this is a point which is very poorly understood. It's very important in what type of lesion you have. If you have an epithelial cell type of tumor origin, like a cystadenoma you will have a benign lesion. If you have a germ cell originating lesion, it could be a mature teratoma, and at the same time, you could have the 3 different types of malignant neoplasms: immature teratoma, dysgerminoma, and the very, very malignant yolk sac tumor. If you have a stromal cell origin, it will go down to malignant neoplasms. The mixed forms, and this is something which are sex cord and stromal tumors, they have been found to be benign. Now, you get a lot of these diagnoses when it's impossible to send a biopsy straight away, because by sending a biopsy, you might even upgrade the whole tumor. So how do we proceed? And first of all, how do we understand how these tumors present themselves? What is the complexity? Some years ago, before this, we brought out this paper in 2008, we were even confused how many types are there. So I went into a massive search with our gynecologists, and we came out with some very important factors based on our patients also. Traditionally, we were doing beta-HCG, alpha-fetoprotein, and CEA. These were the three markers that we were seeing in our patients. I think what is very important to add to this complete armament is CA125. As you can see, it comes in a lot of malignant tumors, as well as in non-malignant ones, so you need to differentiate again. Non-specific annulase, which should be added, HP, LAP, and of course LDH is sometimes a very simple marker which you can get the values quite early so that you can decide in which direction you have to proceed. As you can see, most of the LDH, although it's not specific, goes in the malignant category. Now, this is what I came up with. With all the histological diagnosis and everything coming together, you see that the ovary has three types of cells, and the origin of these cells could be based on the stromal cells, which you can see in the orange types over here. It could be germ cells, which you can see in the purple category over here, and the epithelial surface cells. It's no wonder that we are totally confused, because these huge number of permutations and combinations that can happen with these type of cells, that we do not correctly understand whether the lesion will be benign or malignant. And what adds to the confusion is the epithelial cells, which are in 5 different types, which are called borderline low malignant potential. And these cells have to be also understood, or these type of tumors have to be understood very carefully. They could be malignant or probably even stay in the dormant state. So once this chart came up, which we published in one of the local journals at that time in Austria, I think it got published in a German language journal, it was very important for us to at least understand the different type of cells and the way that these cells are trying to go into different direction, and the complexity of understanding the entire tumors in the ovary or associated with the ovary. This year, in the Journal of Pediatric Surgery, of course, as the topic is endoscopic surgery, we published a meta-analysis and a systematic review on the laparoscopic versus open approach to ovarian lesions. Just to summarize, it is quite a big and extensive article what we published. We just saw that operating time favors the laparoscopic approach. Of course, there were neoplastic and lesions which are more or less we were identifying them to be benign. Of course, no malignant tumors were taken in this group. The hospital stay also, as you can see, favors the laparoscopic approach. With regards to two things which we looked at, one most important thing was intraoperative bleeding, again favors the laparoscopic approach. And when we looked at complications, this also, the odds ratios favored the laparoscopic approach. So definitely there has been an advantage of using laparoscopy in managing of these tumors. The problem comes for giant teratomas, and according to the Royal College of Obstetricians and Gynecologists, their guidelines, they recommend a laparoscopic approach to be considered as the gold standard for management of all benign ovarian masses. But there is a caveat over here that the maximum size of the cyst, which laparotomy should be considered, is still controversial. Nobody has decided what should be the mass, with most of the investigators recommending laparotomy for mature cystic teratomas of over 10 centimeters. So 10 centimeters more or less has been considered as a baseline, that if it is over 10 centimeters, go for an open approach and do not take the laparoscopic approach. I present a case series of mine with 3 patients presenting with ovarian giant teratomas. All of them were greater than 10 centimeters, and all these 3 females were less than 12 years of age. So the size was 12 and 14 and 15 centimeters. And as you can see, the case series selected 3 females who presented with masses 10 centimeters. Very important to have an MRI imaging, and I made sure that there were not any malignant components, otherwise I wouldn't have done it laparoscopically. as I said, tumor markers very carefully included in the preoperative workup and were found to be negative. So that's why the process was also done as endoscopic procedure. Now, these are images of those tumors. And I think what is very important when you have mature teratomas is how do you proceed with these tumors? I prefer the ovarian sparing surgery. So as you can see in figure 1, very carefully, you find a part of the tumor which you can just scorch on the top, even using a simple hook. And once you've got it scorched, I prefer to take in the ligature and try to work around the tumor, trying to get it off, release it from the complete capsule. Once you're in the right layer, this can be a little bit tricky because you do not want any spillage and you do not want any bursting coming out of hair or tooth or whatever you might have in a giant teratoma. You can very carefully push down just using your ligature to get around this tumor mass. Be patient because there are blood vessels which you'll have to keep ligating so you do not have a bleeding. As you can see, progressively, you can start exposing the entire tumor away from the ovary. And once you have done that, you can see this is the ovarian part and the tumor with the cystic part, no ruptures over there, pushed out on the side. Bring in a large endobag, and once you have bagged the entire tumor, you take it out through an incision through the umbilical port, just extend the incision maybe by 2 centimeters on the skin, but using that, extend the incision by around 3-4 centimeters on the fascia level so that you can get this mass out safely in a bag, avoiding any spillage at that time. So the masses were all removed. The operating time is a little bit more than what you would expect because you need to make sure that you're not doing any rupturing and there's no rush into these surgeries, and all the tumors were removed without any rupture. I kept following these patients, and I think it's very important because if you want to do some work like this and you're saving an ovary, you should know how the ovary is working. We looked at the residual ovarian follicles in the scans in these patients. The 2 patients that went this surgery without the torsion, that means these patients presented to me with lower abdominal pain, no torsion. When I did the MRI scans, they could take them into surgery. And I found that these patients, even after 5 years, had 10 follicles per ovary, which is very, very good for the residual ovary to come back and curl up and get back into function. However, one of these 3 patients had a torsion. That's how she presented. And it was very important that we went inside. The ovary was not looking good. It was quite dusky, but I preferred again to go ahead with the laparoscopic approach, did the complete removal of the tumor mass. But this ovary still, as you can see, is still able to produce 3 follicles, which means it has some residual function. And it would be rather an easier operation if I would have just done an oophorosalpingectomy, but I still am a proponent, if it is possible, try to save the ovary, even if it has minimal function. So, summarizing my approach for ovarian torsion and with or the absence of cyst. If you have a pure cyst, like I mentioned to you, go for laparoscopy and you can do an oophoropexy, or I prefer to do an oophoropexy. I will come to management of the pure cyst in the next few slides because there's also a lot of controversies and lots of techniques with everyone proposing his own technique to be the best. The problems come when you have mixed solid cysts, you have half cystic and half solid structure, and the tumor markers are negative. That means you are safe. That means the patient is okay and pain is not severe. You can progress with the laparoscopy. Detorsion, if you have a torsion like I mentioned on the top, ovarian sparing tumor removal is possible in these cases. The problem comes when you have mixed tumors, that is solid and cyst. Tumor markers are not available and you're not very sure, but what the tumor markers, especially the first 3, which you can get quite early in your lab. In this case, pain is severe. That means you know that the torsion, if you wait for 2 days for the tumor markers, you might get into trouble because you might lose the entire ovary. Go in for open surgery, no scope for laparoscopy in this case, detorsion only, and leave it inside over there. You can always come back to see what it was because you have no idea about the markers in this case, and there's no point in losing the ovary. Just detorsion, no oophoropexy. You do not want to injure anything on that surface. You do not want to cause any kind of spilling. Just leave it back. In 2-3 days, you will get your markers back, go back into abdomen and see if you need to save it or remove it at that time. Solid, there is no question about it. Just go in for open surgery and for tumor removal. no scope for laparoscopy in this side. Now, something which bothers a lot of people, and whenever you hold a talk, and that is about neonatal ovarian cyst. There was a hype in the 90s. Everyone who could put a scope into the abdomen was very happy to put in a needle, and most of the articles you saw came out in the early 90s that, I could manage an ovarian cyst. This is when a lot of suturing and knot tying techniques were not well known or not well practiced, and people were not doing complex procedures. So my question was, again, is the endoscopic hype over? Let's see what is the information that we know about it and how we are proceeding with these cysts right now. The most important thing is ovarian cysts, first of all, came into reporting in 1975. These are the antenatal diagnosis. Why? Because till that time, almost we did not have ultrasound. It's only after this time that ultrasound came in. If you see the very early images of ultrasound, they were nothing that what you have compared to right now. You can see beautiful images. You can see some dusky figures, but I think it was a big achievement in 1975 also to detect antenatally ultrasounds with the ultrasound ovarian cyst. Now, let's keep some benchmarks in our mind. Simple cysts are less than 4 to 5 centimeters, and they tend to resolve spontaneously within the first 4 to 5 months of life in the babies. Surgery is recommended for simple cysts greater than 4 centimeters, as they have a high rate of torsion in the future, or complex cysts that have undergone torsion already. That means the cyst is completely changed its morphology, and I will show you an example of that. Now, ovarian cysts and the time of prenatal detection, this is important for fetal counseling, which is very common in our country, that when the parents come to you, this is done in the 3rd trimester of pregnancy. That is when the cysts are diagnosed. It will not be diagnosed in the 2nd trimester or never in the 1st trimester. Fetal ovarian cysts are derived from normal follicles, and they increase in number during the 3rd trimester. So that is very important when this ultrasound scan was done. Now, torsion and infarction complications have been very less understood, and I went again through a lot of literature, because for the fetal counseling, as parents keep asking you what could be the implications of a neonatal ovarian torsion and what could be done. First of all, this could lead to infarction, and it has been found that intestinal obstruction could be one of the problems. Compression of the urinary tract with a large cyst, even the compression of the vena cava has been documented. Cyst rupture, which has also been documented as early as 1975. Bilateral ovarian loss, that means the rotation and the torsion of the cyst in the abdomen, and then after that, by the time the child does or the baby is born, there's nothing left. And the cyst incarceration in the inguinal canal or in the canal of Nuke. Now, what exactly is the definition of a complex neonatal ovarian cyst? They have 4 characteristics which should be well understood. They have a fluid debris, that is a fluid level, which you can see in the image on the side. The cyst appearing with the retracting clot, that is also a very important part of a complex cyst. Septations with or without internal echoes, and it could have also solid appearances. So these are some characteristics. If it is not purely cystic, you will have to classify this as a complex neonatal ovarian cyst. Coming towards the end, there was something which is very important, and this is, again, a systematic review and one of the best meta-analysis that I have ever found. 34 studies were included in the systematic reviews, and 954 fetuses were analyzed. In 53% of these fetus, the cyst regressed during pregnancy, and that is very important, or after birth. So one thing is important to know, that half of these antenatal scanned ovarian cysts will be removed or will just regress on their own. The likelihood of resolution was significantly lower in complex, and it was also lower in cysts less than 4 centimeters. So these 2 parameters have to be kept in mind, that if you have a complex cyst, it will not resolve on its own, or if you have a cyst greater than 4 centimeters, that will be something also which you'll have to follow up and make sure that this patient requires the proper treatment. Now, the second important part which this meta-analysis brought was that there was a change in ultrasound pattern of the cyst, which was associated with an increased risk in ovarian loss. That means if you see that the ultrasound pattern is changing in these cysts, you can either have an auto-amputation of this cyst. That means you've seen a cyst and over time it has changed, then it could be that, or later on the child will need a surgical removal. The risk of ovarian torsion was significantly higher in cyst, measuring greater than 4 centimeters versus lesser than 4 centimeters. And this is, as you see, a very nice meta-analysis based on a huge patient population. The sample size was absolutely fantastic. Now, the likelihood of postnatal surgery, again, in this was with cysts greater than 4 centimeters and cysts which were complex. Very, very important. And one thing which was very important in this complex, we know, yes, but this was irrespective of size. So even if you have a complex cyst, which is 2 centimeters or 3 centimeters, which is smaller than the threshold, this child will have postnatal surgery. Now, what did we learn from this? I'm sorry. In cases undergoing prenatal aspiration of the cyst, and this is what a lot of parents ask you, the child has a cyst, doctor, why do you think my gynecologist or my obstetrician can just put in a needle and just aspirate the cyst? And these are very important answers on that aspect. First thing is the rate of recurrence for a cyst that is undergoing prenatal aspiration is as high as 40%. So you can do it prenatally. You will see in 40% of these patients. I don't know, somebody else is talking right now. The other question was the cyst that underwent prenatal aspiration, you still had a chance of postnatal ovarian torsion as high as 10%, very, very high. So that is again one of the things which was very good in this meta-analysis. Postnatal intracystic hemorrhage, that means the point where you punctured starts bleeding into the cyst, and that is very high when you see it. It's 12.8%. Postnatal surgery was necessary despite having a prenatal aspiration in 20% of the cases. So I think this is very important data when you talk to parents, and the parents hoping that you just puncture the cyst simply and you get out and the problem is resolved. It's not as simple as that. And that's the reason I like this meta-analysis, which really showed that prenatal aspiration, yes, there is a good 70-80% success when you add all the figures together, but all the 4 different problems were very nicely identified in this paper. Now, neonatal ovarian cyst, the algorithm which is suggested, you have simple cyst, smaller than 4 centimeters, asymptomatic, just follow them up. No need to do anything. Larger than 4 centimeters or smaller that are symptomatic, just go in for surgery. I will come to the next point of the surgery and the surgical approach. And complex cysts, more or less, they will end up as surgical cases. Now, again, the laparoscopic approach, and if you are trying to look at the literature, very, very confusing. Let's start with what has been said in the literature. 1995, Van der Zee described 2 cases of laparoscopic assisted cyst mobilization and resection through a lower 1 centimeter abdominal incision. So that means you identified it laparoscopically, but the surgery went as an open procedure. 1997, chronologically, Maria Bailes and Marcelo, they described a technique using 2 to 3 trocars, I would call them ports, with cyst extraction through a 10 millimeter umbilical port. So this procedure, which was also described for cysts in the ovary, were also laparoscopic assisted. 1999, the next technique with Decker, he used a 3-port technique, and this is the first one which I saw that there was intramanipulation, operative manipulation of the cyst, and the cyst which was also managed intra-abdominally. After that, 2002, now you see we are coming to our years closer, a 2-port technique was used with extraction of the cyst through a 5 millimeter intra-umbilical incision. So still open surgery or ovarian assisted surgery being used in these children. And in 2007, a technique with laparoscopic assisted transumbilical cyst extraction was done. So you see, most of the techniques which were published till 2007 involved laparoscopic assisted approach to cyst, which I am not too much in favor of. So either you do it laparoscopically, or now at the present stage, I wouldn't do anything which is laparoscopic assisted. Now, the question is also, what is the threshold? Depending on the clinical features and the postnatal ultrasound, especially if cysts are 4 centimeters, we always talked about less than 4 and bigger than 4. What if they are 4 centimeters? Just the middle, which can happen for a lot of children. There is a big discrepancy in the literature. And this is what adds to the confusion with regards to the timing of surgery. Newborn, do you want to operate it immediately when the child is born or the baby is born versus later when the child is symptomatic? And as you see, I've gone through most of the literature right now, and there is no consensus on this. So very difficult to give you an answer what to do if the child is newborn and tell the mom, you know, I think it's around 4 centimeters and we need to get rid of the cyst, or it's larger than 4 centimeters. Which date do you decide this? This has not been worked out very carefully in all the publications that have come out to date. Now, again, there is no randomized control trial with regards to the different techniques that people are propagating. The ultrasound-guided puncture, you know, is something which is practiced by a lot of people, that you just use the ultrasound and do it. And also versus cystectomy, that means removing of the cyst using laparoscopic procedures that we do, creating a window, which is my technique, just pure laparoscopically creating a window over there and just fenestration and just getting out over there. But there is no randomized control trial. Laparoscopic guided puncture, as you can see in this, you can see that where the cyst is and just doing the puncture. Again, we do not have a randomized control trial. And even the authors have reported very early results. Nobody has been following up these patients for a long time, so we do not know much more about these. And the confusion of the range of laparoscopic approaches, there is no consensus. There is just simple aspiration, cystectomy, that is just removing the whole cyst with a circular incision around it with electrosurgical devices, decapsulation, stripping, oophorectomy has been also described in the literature. So unfortunately, we all are practicing management of simple cysts with what we think is correct based on these few reports that are emerging in the literature or have emerged in the literature. Unfortunately, I have to say again, there is no randomized control trial in what is the right way to go. I think it's worth looking into a randomized control trial, so at least we can get a consensus based on what is correct at a higher level of evidence. Now, with viable ovarian tissue, that is another question what is asked. The surgical technique reporting has been very unclear. What are you doing with these tissues? This is again with regards to a cyst, oophorectomy or cystectomy. Now people say, I do a very careful cystectomy and I remove only the cyst and I leave the ovary in place. This is not correct. There has been viable tissue found in all oophorectomy specimens. That means you can see that even when the ovary is removed or even when the cyst is removed, that there is a lot of viable tissue that you remove in these children. So for me, this does not come as an option. And a very important publication that came out 3 years ago, attempts were made to preserve normal ovarian tissue on the ipsilateral side as much as possible. Even in this study, you can see that when they remove the cyst wall, they removed a lot of ovarian tissue. So my approach based on a lot of this, again, there is no randomized control trial. The best thing, because of the evidence coming out now, is to put a fenestration, leave the tissue as much. I think, and the way the literature is showing, again, it's not based on a systematic review, is that if you just do a simple puncture, the chance of recurrence may be higher. But like I said, most of the patients have never been controlled for a very long time. Now, the differential diagnosis of neonatal ovarian cysts, this is something which bothered us, and I will show you the case why it bothered, is that you see a cyst in the abdomen. If you see the cyst in the lower part of the abdomen, you can say it's an ovarian cyst, but it's not very simple. It could be, this is a nice publication in 2010, it could be a mesenteric cyst, it could be an omental cyst, urachal cyst, it could be a duplication anomaly, anomalies of the intestinal tract or urinary tract that could cause obstruction, cystic meconium peritonitis, hydrometrocarpus, and anterior meningocele. So it's not very easy. It's not so simple just that you see the cyst and around the ovary area and you say, I think it's an ovarian cyst. You have to be careful also because it might turn out to be something else. This is one of the patients which we had, which was a floating neonatal ovarian cyst. Now, this was a child that was presented to us, and it came with a cyst. We looked at the cyst. It was just under the liver. So we thought, first of all, it could be some kind of a hepatic cyst. And very early in 2004 or 2002, I can't remember very well, I published a case with management of a hepatic cyst in a newborn. But something was a little funny, as you can see, as I mentioned, in the complex part of the cyst, there was some clotting on the side. Did not make sense. The next day we got a second ultrasound, and the second ultrasound showed that the cyst had migrated into the left side of the abdomen. That was again confusing. A cyst which I thought was probably something to do with the liver or with the biliary tree has now migrated to the left side. Child was doing well, and we said, okay, let's wait for one more day. And then we saw that the cyst migrated into the lower abdomen. So this is what I call a floating cyst, and that added to the confusion where it was. Of course, the best approach in this is to find out laparoscopically, and this is what we found out. Now, this is not very easy to understand. You see these whole load of bands which are associated with the ovary. So finally, this was an ovary that had undergone an antenatal torsion. And because of the antenatal torsion, the bands which you're seeing on the top that tried to do the tourniquet of the ovary, this was the omentum that was wrapped around it. So the ovary had been completely amputated from the point. As you can see, the fimbriae over here, which are almost calcified on this side, and we had this huge mass of cysts floating around. Of course, we sent it for histological analysis, and you saw that the ovary, there was nothing left in that. It was just a whole calcified mass. It had to be removed, and of course, my approach, like I said, is I prefer to fix the other ovary because I'm in there laparoscopically. And this just highlights this floating mass case, which makes it more difficult at that time when you're trying to decide whether it's an ovary or something related to the liver or to the spleen. So going through all these complex cases, I would just like to summarize that the approach to management of ovarian pathologies with endoscopic surgery highlights the following things. It offers diagnostic opportunity to show both the ovaries. That is the most important thing. The second thing, it allows for aspiration of the cyst under vision, if you'd like to do that, or to do even a cystectomy or removing of the cyst. But like I said, my approach more or less has been to just create a window and just leave the rest of the mass as it is. I would like to preserve most of the ovary at that time. Oophorectomy is for the streak gonads, very, very important. There is no place to leave any part of the streak gonads. And as you also saw, in the Frasier syndrome, be very careful. If you have a nephropathy and a streak gonad, you need to remove it and immediately see if there's a malignant transformation like a gonadoblastoma, and then the child immediately goes in for further oncological treatment as chemo or radio, whatever might be necessary depending on the stage. A very careful approach to ovarian masses. Again, don't go in very fast laparoscopically if the mass is not completely identified as a mass that is benign. You might get into a lot of trouble with the malignant mass that you've tried to do something laparoscopically, you've done a spillage, you've caused an upgrading, and that can be a disaster for the child. It might even lead to the loss of life. In the series which I reported in 2008 in European Journal of Pediatric Surgery, there was one death, and that was due to spillage and upgrading of the tumor. It was very difficult. Salvaging of the ovaries is now something which I consider very seriously when I see a patient with torsion. No matter how bad the torsion is, my approach is to leave the ovary in place, detorque it, fix the other ovary. My, again, opinion, but of course, this is it. Like I said, it's not evidence-based, and even PEG seed ovaries can turn. Is to leave it, and then, as I mentioned, after 5 years, when I do ultrasounds, I still see that there are 3 or 4 follicles coming in. But I would need a large number of sample size to actually have a concrete opinion about this. The most important thing when I come to the end is that the evidence for the best approaches in endoscopic surgery is still necessary when you look at these pathologies. Thank you very much for your attention. I'll be happy to. questions. Yeah.
Amulya, thank you very much. We enjoyed it. I'm sure that everybody enjoyed your talk. And right now I'm going to ask the audience if there are any questions or comments. So if it's okay for you,
Yeah, that's
I
fine.
will,
Yeah.
I will ask them in Turkish and see what they're going to say, okay? Meltem. Meltem. Mikrofonunu açarsan konuşabilirsin sanıyorum.
Duyuyor musunuz?
Duyabiliyoruz, evet. Dinliyoruz.
Dr. Amulya, thank you very much for your very nice presentation. I enjoyed it very much, and it's on a difficult subject with lots of controversial aspects. My question is, if you have a patient with mixed mass, mixed ovarian mass with solitary and cystic components, and you have negative tumor markers, what would your surgical approach be? What would you do? Would you take samples from peritoneal washings, or would you do biopsy, proceed with salpingo-oophorectomy or lymph node dissection? That's my question.
So you have a mixed mass. That means a lot of teratomas, as you know, have cystic components, and they have also solid components. And both these components together, as you know, do not pose any major risk in terms of that you have tooth or you have hair, which is not a big problem. Like you said, there are negative markers, and that means I'm very safe to go in laparoscopically. You have to be very careful, and I think there are a couple of very nice videos. We will be also publishing our approach, how you manage them. Be very careful, because on the top of the solid mass, it's very difficult to start your dissection. You will open your area on top of a small cyst that allows the monopolar hook to make you a space to work in over there. Once you start doing that, you can completely take off the whole mass. Peritoneal sampling, as far as I know, is not a normal procedure that we do in these patients. And I would like to also stress that once the markers are negative, it's very difficult, or at least now in over 25 years or 26 years of practice, I've not seen that we've done anything wrong with these mixed tumors which have negative markers. If they're positive, any of the markers, go for an open approach. The dilemma comes in these patients maximum when you have an associated torsion or they come with severe pain. At that time, sometimes ultrasound or Doppler ultrasound may be helpful to show you that there is normal blood supply to the ovary. But even the ultrasonographers are not very sure about it. So now you have a child, you're not very sure of the torsion, there is pain, you see a mixed mass, you do not want to do an open surgery at this stage. My approach would be go in laparoscopically, very careful with your instruments, flip the mass, bring it to the normal position in case there's a torsion. And in case there's no torsion, just see the mass and come out, don't touch it. And you have always the time to go back in again, either laparoscopically or open. You're not doing anything wrong. The only emergency at this time is because of a torsion that you do not want to lose the whole ovary.
Thank you very much.
There is another question. Nihan Ünver. Nihan?
Would you like me to ask in English or would you like me to write?
How do you prefer? If you like to ask in English, you can go ahead and ask.
Okay. If you have a para-ovarian torsion, which seems the tube is prolonged, do you prefer a contralateral fixation? I'm not really sure what you mean by the fixation. If we have a para-ovarian cyst torsion in, let's say, right side, do you prefer a fixation for the left side, which is normal?
Yes, my approach is while I'm already in there, and like I said, there have been parameters, but nobody has been able to clearly define the parameters of ovarian torsion. Like I said, this subject has been more or less on the small studies that have been presented everywhere. We, at least at the time in Graz, or when I was working in Münster at that time, so much ovarian torsions were not being done laparoscopically. In Graz, the ovarian torsions, the ovary, which was quite discolored, was anyway left in position and fixed over there. And in Graz also, we had a lot of removal of ovaries because that time it was not very clear to rescue all the ovaries also. But the normal ovary and the contralateral, that has been my practice to fix it. While I'm in there, just put an extra stitch and fix it. Again, I showed you the data. It's not evidence-based. It is what my practice is to fix it there. So instead of coming back or the child coming at a later stage with a second or a ovarian torsion on the other side.
Thank you.
Okay, thank you. Ergun, it's your turn.
Okay, thank you, Mr. Saxena, for your nice presentation. I will also ask a question about oophoropexy. So it seems like we are doing a very harmless job performing oophoropexy to avoid a worse thing such as ovarian torsion or something. But is it really that harmless? And are there any studies that you have encountered in the literature on ovaries that have been fixed? What happens next? What happens then? Or are there any intraoperative complications or postoperative long-term complication of oophoropexy?
My opinion, and the reason I pursued with that for a longer time, because we followed these patients for quite some time. I do not recollect any intraoperative complications at all. What I mentioned to you very carefully, the site of the pexy is just where the site of the iliac vessels are there. So you have to be very careful to pinch the peritoneum outside while you pass that stitch. If you're going to pass it through the vessel, God help you, you've created a massive problem at that time. So be very careful, pinch it out. That peritoneum is very lax. Put the nice stitch on that. Put 2 stitches on the ovary. I don't think a single stitch is going to hold that. It will still rotate on its own and going through that. I've not seen any post-operative complications in my series because most of the patients, at least I follow them up for 5 years. Now, if you can imagine, I've operated a patient who's 13. At the age of 5, when at the 5 years, she's 18, she's not going to come back to a pediatric surgeon. So what I'm trying to tell you is, unfortunately, these patients, like in testicular torsions also, or when you do a lot of these Fowler-Stevens, they're lost to follow-up because you would like to, for example, I'm just changing the subject a little bit, in testicle undescended testes also, you do not know what is the sperm count because you're not going to chase the child after 20 years to get it. So these are some things which are very difficult to answer. The practice is, yes, I pexy both of them, and now my approach is no matter how dark it is, I would like to save them and give antibiotics for a period of 4 or 5 days. Tell the parents, fever, the child is going to be sick, don't worry about it, we're going to cover it with antibiotics. And I think that was a very important publication that if you tell the parents about it, they're expecting that. And like also I mentioned, there are follicle counts which come after maybe 6 months, you can do the ultrasound and you can see it recovering. But a lot of more data is required from many, many centers if you want to have at least a sample size of 100 to make conclusive evidences or statements on this.
Thank you. Another question from Çağrı Savaş.
Thank you. Thank you, Dr. Saxena, for your nice presentation. I would like to ask you, which tumor markers do you prefer to study in mixed tumors in every age group of patients? Do you study every tumor markers that you presented in your slide?
I think that you're asking a very important question. And I would like to go back to that slide, which is something which we looked into. I will share the screen straight away. Can you look at this slide? Is everyone?
Yeah.
Okay, so
we can
when you
see.
look at this slide, let me just come out on this way. Okay, you see that the reason we missed a tumor and the reason we also had a death in the child led me to do this study. Because the 3 markers on their own, the most 3 common markers that we are taught in any medical school or when you're a young trainee is alpha-fetoprotein, beta-HCG, and CEA. That's what I was taught at that time. And I think that is absolutely right because people who have done more investigations on CA125 know that it is not very specific, this marker. But if the child is not having a torsion or severe abdominal pain in which you have time to wait, go through the different markers. And that was the reason we did this publication, just to make people aware of it, that we would like people to have these 5 markers plus LDH, which will give you some kind of idea. Now, again, when you look at our report that we published in 2008, it was based on 76 patients, not so much. We would ideally love to have hundreds of patients with tumors grouped in together to finally get this data out. But my approach right now, whenever I do alpha-fetoprotein, HCG, LDH is done anyway. You get it very fast in the first study, but within a few hours you have the results. CA125, I do non-specific annulase, but some labs refuse to do it because they do not do this kind of testing. And HPLAP, this is something which I prefer. So that's the reason also we went ahead with the publication to see that, is that possible that only with these 3 that we detect everything, or do we need something more?
Regardless of the age of the patient, for example, in a neonate with mixed tumor, it's probably a teratoma, but you also study every a marker almost.
No, in a neonate, my approach would be to do the 3 traditional ones.
Yeah.
AFP is the most important for the neonate. And then after that, if you have the opportunity of doing beta HCG or CA, but I do not recall any of the massive neonatal mature teratomas that were operated as neonates. I cannot recollect that so much. Maybe they were missed out on screening, or we do not have. Most of the teratomas come after some time, at least in the patients that I've managed.
Thank you.
Thank you. The next question is from Arzu Shenjan. Yes, Arzu.
Hello, everyone. Can you hear me?
Yes, we can hear you well.
Okay. I would like to thank very much to Dr. Saxena for his nice presentation. My question is also about the site of the fixation of the ovary, because we know that among gynecologists, there is a concern of ectopic pregnancies in the long run. Do you have any idea about this subject? Because we don't have the chance to follow the patients in the older ages. Have you read anything about ectopic pregnancies after orthopexies?
I'm sorry, I cannot recollect right now while I'm sitting here reading any publication of children having ovarian torsions and oophorepexies, which later had ectopic or normal pregnancies. I think, again, huge positivity on the data on this thing. I can't recollect even a single case of something like that, which was followed by a pediatric gynecologist and later on studied by adult gynecologists with regard to pregnancy. So I must admit, I might probably have to go back and look into the literature if there's something like this, but at the present moment, not that I'm aware of.
Okay, thank you very much.
Okay, the next question is coming from Hilmican Ulman from İzmir. Yes, Hilmican.
Thank you very much for your nice presentation, Mr. Saxena. I'm Hilmican from Ege University in Izmir. I was going to ask a similar thing like the previous question. Do you have any experience about the effect of fixation in the adult age? We have an ongoing research and follow-up of the patients, and we showed that the fixation of the ovaries can cause very high rate of menstrual pain in the adults post-fixation in the long term if you leave a permanent suture inside. Like a similar question about long effects. Thank you.
I'm not very sure that I've come across this problem. The other thing is I'm also not very sure, as you probably know, that there's a huge discussion even when you do fixation of testicles, what is the optimal material that allows fixation, that allows, again, retorsion of the testicles. So there are people who prefer monofilament sutures, non-resorbable. There are people who prefer vicryl fixations, hoping that the fibrosis will stay over there. And then there are people who prefer something which is braided and non-resorbable. So again, on that side, the question has not been answered. On the ovary side, I don't think I'm not aware of this problem that, the fixation of the ovary, because that it has again opened up. As you see, there was only one report which I've seen that you fixed an ovary and it again had a torsion again. So, but this report does not show the type of material used. With our series, whatever we did not have torsion does not mean. You can see the series are of smaller size, but the report of, and the whole question of fixation and not fixation is still not answered. People have not been absolutely sure, should it or should it not be done? So it is still very, very controversial, and that's why most of the topics which I brought up for discussion today are the topics which are not clear. Most of the people prefer and think that the ovary is such a simple organ, you know, you just have to either, if it is completely torn, just cut it and throw it away. If it is just fixation, oh, I don't do it, I do it. But I cannot tell you the evidence. I cannot even tell you the evidence how they were fixed with which material as a child that they later had problems at the later age. I cannot give you any evidence-based data on this thing.
Okay, thank you, Amulya. And the next question from Gonca Tekant. Yeah, Gonca, we are listening.
Okay. Amulya, thank you very much. We really enjoyed your speech. The question comes regarding the simple cysts that are functional. They're secreting estrogen. Those group of patients can be quite troublesome to differentiate if it's just a functioning cyst that will regress in time, or if it's actually a functioning, tumor that can be cystic in origin. How is your approach in those cases?
Well, as the literature and what we have seen also, because we are very careful in doing ultrasounds in these patients, especially because I'm involved also in the fetal counseling, so I know the parents from before. I know the size of the cysts, which are done on the prenatal scans. Postnatal scans are done. My feeling is a lot of the simple cysts, like also what the literature is stating, by the 6-month scan, they are very small in size or almost disappearing. So most of them will not be operated at that time. The other question is, which I raised it and which we cannot find anywhere, and multiple publication, what is the optimal time for operating? You're always afraid because the cyst is around 4 centimeters, and I'm saying around 4 centimeters. If it is 5, you will wait for the first scan in 3 months and look at the scan. If the scan is again showing that it is increasing in size for whatever reason, I would rather go in and, laparoscopically at least manage it with the small window. This time is enough time to give you an idea if there is any kind of malignancy. I mean, of course, if there's a cyst which is persisting over 5 or 6 months, I would just do the tumor markers of the child at that time. Very difficult again. If it's a complex cyst, I think the answers are a little bit more easier, but a simple cyst, most of them have the tendency of regression. And the regression is something you follow it later on with the 1-year scan and then leave it at that. Beyond the 1-year scan, if the cyst is still persisting over 4 or 5 centimeters, my approach would be laparoscopic intervention.
Thank you.
Thank you, Gonca.
Okay. Amulya, there are 2 more questions from the audience. One is coming from Burak Tander. He's asking what to do in a case which is a torsioned ovary with emergent surgery and found a mixed teratoma during the surgery.
Yes, it's so the approach is that you can, like I said, emergency also, I prefer the laparoscopic approach. It's a mixed tumor, you know that. Detorque it and leave it in position. Just don't do anything after that. No stitch, nothing at all. Don't puncture any capsule because any leakage at that time by mistake will cause a upgrading. If it is malignant, you get into trouble. Just detorque it, bring it back, go after 2 days. By this time, you will have your markers. You will have an idea what is to do with this. If you need to go back in again, you can go back in again. And at this point, I would say I do not agree with oophoropexy. No oophoropexy in these ovaries when you're not sure of a mixed mass.
Okay. There is another question coming from Doğakan Yiğit. They're asking about, do you ever recommend making a biopsy after ovarian torsion, like prepubertal patients or something like that?
I've never practiced this approach of taking biopsies in a torsion because everything looks quite black and engorged at that time. When you have a horrible torsion, and I had a very severe case in which I had the torsion of the fallopian tube. The fallopian tube was gone, it was choked, and the ovary was completely black in that child. And it was something which I was not very sure to whether the fallopian tube will recover in function. I can bring back the ovary will recover, but the fallopian tube, I'm not very sure if it will recover. So what to do in these cases. So in that one of these child, this was before I started investigating into ovaries more carefully, I did a full resection. But the next child, what I did is I returned I just did the detorsion, left the ovary in place, left the fallopian tube in place. The child was in London, then the parents moved to Germany, but the mother was very kind that every year when they had the follow-ups in Germany, they send me the ultrasound report. So, I like to follow up, because if I'm doing something, I would like to know if that was completely gone. So this child's follow-up also showed that there were 3 to 4 follicles present in that ovary after 5 years. After 5 years, I stopped following them up, but this was quite a good evidence that even if you have a tubal torsion, you can leave it in place.
Okay, thank you, Amulya.
Yeah.
Okay, I'd like to ask a question. Do you have any experience about the transposition of the ovaries in oncologic patients who's going to have a pelvic radiotherapy?
I do not have myself any experience, but I know Sabine Sarnaki in Necker in Paris, she has the experience, and she's also published a good amount on that subject of ovarian preservation during the chemotherapy or protecting the ovary for the girls at that time. I think it's very encouraging if you have something like this to protect the ovaries. I have not practiced it, but I think that is something very fantastic what she's doing with that kind of work.
Okay, thank you. And the last word is for our chief of departments, Professor Çakmak. Yes.
Hello, Amulya.
Hello.
Thank you very much for your nice presentation. It was very pleasure for us to listen to you, and thank you for your kind efforts for sharing your valuable time for us. Thank you.
Thank you.
Okay, Amulya, we thank you very much again for your time, for your efforts, and for being with us this night. I'm sure everybody is very happy about the talk and also the questions and answers part. And if you are going to tell something more, please go ahead and tell. Then I will close the session in Turkish.
Well, I think it was, first of all, very nice to see all my Turkish friends, on the multiple screen over there. And, as we are having a very difficult time, interaction between people is very, very little. There are certain people whom you interact more. So I would like to thank the organization for giving me the opportunity and choosing a topic. As you know, I offered you 3 topics for this meeting. It's very important to look into controversies. Some things which look very simple are very difficult. And when I was a trainee, the most simple thing was an ovarian cyst or ovarian torsion or an ovarian mass. It was just remove or just fix it or just make a small window into it. The more that you look into these pathologies, you see how complex issues are, and especially when you have to do fetal counseling and manage these patients. I thank everyone for their attention, and I thank everyone for asking me the questions, and I hope you stay safe in Turkey in the pandemic. It's a very difficult time for everyone, but keep yourself safe and your family safe in this time. It was nice seeing all of you.
Okay, thank you very much, Amulya. And please stay safe for yourself also and your family and other friends in England.
Thank you so much.
Herkese çok teşekkür ediyorum. Söz alan başka kimse olmadığı için de toplantıyı kapatıyorum. Gelecek hafta yeniden görüşmek dileğiyle diyorum. Hoşça kalın.